So good afternoon, everyone. Real pleasure to welcome Orson Zhu to our webinar series. Orson is now an assistant professor at Columbia University with appointments in biomedical informatics and computer science. He's also a visiting faculty at Google. His work sits exactly where the future of health is being built, at the intersection of human-computer interaction, applied AI, wearable sensing, clinical data, and everyday well-being. But I want to add a more personal note. Orson is also a graduate of our NIH Health Training Institute, and it's been a pleasure to watch his intellectual trajectory. Even early on during the institute, he showed a unique combination of technical sophistication, human sensitivity, and scientific ambition. He was never interested in technology for its own sake. He was interested in whether intelligent systems could actually help people live better, healthier, and more supported lives. So that's why today's talk is so timely. As AI moves from the lab into the routines of daily life, Orson is asking one of the essential questions. How do we build human-centered AI systems that clinicians can trust, patients can use, and society can benefit from? Join me in welcoming Orson.
Thank you so much, Vivek, for the very warm introductions. It's a great honor to be invited to this event and to be able to give a talk. Let me go ahead and try to share my screen, and hopefully the slides will be able to show up. Can you see the slides with the title?
Looking good.
Awesome. I'm trying to go to the next slides. Did that move on? Let me just double check. Nope.
Still waiting.
Okay, I guess probably.
There we go.
Good. Now it's good. Okay, fantastic. Well, yeah. So as Vivek said, my research is kind of spread across the daily wearable data and everyday well-beings, and try to think about how we can leverage this data to increase the health impact on both the consumer health perspective and also probably in the clinical health aspects as well. So yeah, a little more about me, Orson from Columbia, and also visiting faculty at Google. And so today the talk is going to be pretty, I would say, casual. So if any of you have any questions, feel free to, I don't know, raise your hands up, or just interrupt, or send the questions in the chat. I'll try to monitor. And for people who watch it online, feel free to reach out to me. My email is right here. Happy to answer any questions. So let me just get started. With the audience here, there's no need to emphasize how important the health is a part of our daily life. And our these devices technology have been advanced in a way so that they can try to detect our many aspects of the health behaviors, right? In the past 2 decades of the development of these daily devices, or in the field of the ubiquitous computing, the devices are becoming pervasive and detect like heart rates, physical activities in a pretty robust ways. They can provide us with some data insights. And there are more devices that are coming up, smart glasses, glucose monitoring, etc., etc. They're aiming to make our daily life and provide more health insights. However, when it comes to more complex long-term behaviors, such as daily routines or mental well-beings, and this the data suddenly become much harder, and it's much challenging for us to leverage this data to monitor this complex behaviors and health outcomes. And so this is kind of like the promise that every device is kind of falls apart when we come about talking about complex and long-term behavior, because they're evolving, they're heterogeneous, everybody is different, and every person only has a limited amount of data. And also with this, there are people generating a vast majority of the data from this everyday devices, but they are more or less disconnected from the healthcare systems. And doctors who are not really used to trained to leverage this daily devices, patient-generated health data, are sometimes at a loss about how to leverage these data outcomes. So this brings you two types of the challenges that our lab currently trying to solve at Columbia, and some of the work also trying to do at Google as well. So the first challenge is, given this complex of data, is how can we build better AI models to better kind of model this complex evolving long-term behavior, trying to capture some signals to predict health outcomes. And the second bigger type of challenges is imagine like 5 years from now that we have, let's say, perfect models. There's still a question of so what? Who's gonna be able to leverage this data and use them into the real practice and then actually change and translate them into the actual health impact. So there's a challenge of how we can make use of the data and AI models after we build these AI and the model insights. So this is basically leads me to talk about the bigger kind of the vision of the research, where we're trying to build a better human AI ecosystems, where we're highlight three key stakeholders. The first was the AI system, about how can we build better AI models, and how can we use AI systems to first support end users, depending on whether they are not in the healthcare systems, they are general consumers, which cares about their health and well-being. When they are in the healthcare systems, most of the time they're patients and about how to getting their healthcare problems solved. And the second type of the so-called human or users in the systems is the health experts, as I just mentioned earlier, who are probably not super familiar with how to leverage our daily behavioral health data and trying to see now with the AI systems and model insights, how we can support their decision-making process to make better call. So that's the overall kind of key stakeholders that are trying to connect together, which can naturally involve the three domains of the research: human-computer interactions, applied AI, and also in the health domains. If I can use one sentence to summarize my overall kind of the visions, it's called computational daily well-being ecosystems, where we're trying to see how we can leverage the daily sensors and connect the three key stakeholders to better sense, empower, and augment our daily health and well-being. So these three keywords, sense, empower, and augment, also becomes actually the name of the lab here at Columbia called the C Lab. And just a small promotion of the lab, we're also looking for talented students and postdocs or even visiting interns. If you're interested, feel free to look up our website and then reach out to us for more details. But again, like the three keywords, sense is about getting the data from these data devices, probably connected with the medical systems. Empower means how can we develop better AI and human-centered tools to derive insights. And finally, augment is to bring these insights back to the users, in our case, both end users and health experts, to finally can translate them into real-world impact to improve the health and the well-being. So in today's talk, given the time that I'm going to have, so I will try to see whether I can first talk about how a system can support on a end user perspective, where I'm going to first of all focus on the consumer side, and then if there's more time, I will try to cover some of the our recent work about how the AI system was able to support health experts in healthcare systems. Overall, I want to show you the bigger picture about how we can build human-centered AI systems, and then can connect all the three dots together. So let me first start with the end user perspective. We're going to first talk about one of the work that we recently are doing, which is currently under revision at Nature, and it's a collaboration between Columbia and Google. And this is actually the work that I was done by majority time at Google. So this, if you search the title of the work, it's called Anatomy of the Personal Health Agent. It has already been put on archive. The first version is already there, so it's more or less public, or already like online. So to provide a bigger kind of vision or the background about this project is basically nowadays we have seen that people kind of like do not go to Google search to ask about their health problems. They have access to ChatGPT, Gemini, and Cloud. They can ask questions directly to them and get the health insights. So, and in the companies like all these major kind of frontier labs, and now there's also venturing into the healthcare domains as well. Cloud has this cloud healthcare. ChatGPT has ChatGPT healthcare, cloud for health, and Google recently just announced their product of Google Health. Right, so all these elements are pointing in one direction where people are thinking about, well, if we in the future we have a personal AI assistant to support health, how would that AI assistant would look like? Right, so I want to present you with a pretty user-centered research approach about how we're going to approach this problem. So imagine in the future, you can have an intelligent version of the agent to support your health. What are the kind of the needs that you'll be looking for, and what kind of questions you probably want to interact with this type of AI agent? So our user-centered approach will always start with understanding the end user's needs, and then we can develop specialized AI systems, combine them into a multi-engine systems, and then finally do a very comprehensive evaluations. So I'm going to quickly walk through all the 4 steps one by one. So first one, always starting to ask about what actually people care about. So for this research, we actually try to collect 3 aspects of information for the triangulation. We including looking into what kind of questions people are asking from the search when they're interacting with Gemini, and also on the Fitbit forum, which is Fitbit now is a part of Google. And in addition to that, we also not only look at what people are naturally asking the question, what they're interested in doing, we're also trying to understand when people already interact with intelligent AI systems, what kind of question they may ask. So basically, the Fitbit launched a preliminary version of a tool called Insight Explorer. You can think about it as a Gen AI tool that have access to your health wearable data, and you can ask questions to them. So we tested in the wild for anyone who is a part of the Fitbit Lab, which is actually open to the public. And we collected about 500 people who have been using them for a couple of months, and then collect the feedback about what are the common questions they would interact and want to ask, or what expect to have for this type of Gen AI tools or agentic tools that can become have the potential to become their personal assistant. We also hold a workshop on the expert side. So we hire 14 experts across UX, product, research, engineering to kind of synthesize from their perspective what people are looking for. So we identify 4 major themes that people usually would ask about. And but before I dive deep into each of the types, I want to say that the data is kind of, I would say, probably a little bit skewed towards who are the ones who own the Fitbit and more or less can naturally become to care about their health and then care about their own data. Right. So this is just a general context. I want to put it out there. And then we can take a quick look at about 4 different type of the critical user journeys. And the first one is about general health knowledge. This is not too different from people may search online. So like, what is heart rate variability? What is resting heart rate? What is HIIT? What are the pros and cons, etc. Those are like general QAs. The second type of the critical user journeys are about their personal data insights, which is basically people want to understand more about their own data. Is there anything that I've done to have the biggest impact on my sleep, blood pressure? How can I, like, is there a correlation between the data I access more? Do I gonna have better sleep? Something like that. So this is actually the majority of the question people may want to be interested about, which is, again, as I mentioned, is probably a little bit skewed towards who is the people who already own the Fitbit or own the personal wearable device, which naturally indicate that they cared about their own data, they cared about their personal kind of health data, and with the insights behind that. The third user journeys are about wellness advice. It's based on kind of thinking about it as built on top of the personal data insights. They also wanted to get actionable things that they can do. How can I improve my sleep quality? If I'm going to train for the marathon, what should I do from now? Right. So this is basically the coaching questions people often ask, and that takes about 20% of the questions as well. The last one is, although nowadays all the frontier labs claim that they're not medical tools, and then they can give some kind of advice, but you always should refer to human doctors. People still ask about 10% of the time questions about their personal medical symptoms. I'm not feeling well. What might be going on? So this is also about 10% of the things that people may interact with probably want to get an answer from the AI agents. So now get a very broad overview about what people usually cares about. Then we can starting to identify a couple of the key skills that we think AI agents should be able to have in order to cover all these needs. So in this work, we identify 3 of them. The first one is data science agent, which is basically think about it as a human data scientist, which kind of directly inspired by the majority of the questions about personal insights. We need someone to be able to look into data and generate insights. Second is a domain experts agent. Think about it as a doctors who kind of have the general knowledge about health and clinical and can probably personalize you given your potential context and provide a personalized general advice from the clinical perspective. In addition, we'll think about have a personal coach, which is kind of like knowing about your constraints, knowing about their preferences, or be able to give the most adaptive and personalized coaching advice. This is apparently also inspired by some of the critical user journeys. So apparently, these 3 skill sets is not like one-on-one mapping to the 4 critical user journeys. We basically can foresee that each of the agents or each of the skill sets can cover multiple aspects of the critical user journeys, and then on the ideal case is combine them together, they'll hopefully be able to cover the majority of the people's questions, given any of the questions that you can probably ask to a personal health agent. So that's an overall picture that we're trying to do. So now when you identify the 3 of the specialized agents, the next step is the development, right? So in the next few slides, I'm going to give a very high-level overview about what each of the agent can do, and also how we develop the system to achieve this. And before I go into the details, I also want to have a disclaimer that this is the work that we done back in the time at late 2024 and early 2025. So some of the steps that you may see over there is going to be probably more or less already kind of, you can probably already see in the current frontier language model directly, because just the field is moving very fast, right? So just a calibration over there. And the second, what I'm going to present over the next few slides, you can think about it as a shell that can put on top of any general language models. So in this work, we use Gemini as the base language model at the bottom. If you want to replace it to be other models, it's also totally doable, right? So first of all, this is a data science agent that whenever you ask questions, something about, like for example, asking for data insights, like did I get more sleep, the days I'm more active, data science agent will be able to look into your step account, trying to identify the data you're more active, and then trying to calculate some correlations and give you the feedback, right? So this is a typical thing about as a human data scientist, will be able to provide you with the feedback. How do we do it? Well, we decompose the science questions into 2 steps. The first is, can the language model write a good plan to do the analysis, right? Identifying the variables, do the data transformation, do the calculations, identifying whether the data is missing or not, and then apply appropriate statistical analysis to the data to provide insights, right? So basically write out the blueprint first. And then the second step is to implement it in the Python code, because Python is most kind of well-resourced the data source for the model to train on. And so if the whole process succeeds, it will proceed. If it's not, it will come back and try to do it again. And we have like a upper kind of upper bound of 5 times the retrial in order for us to get insights. So this is a 2-step account for the data science agent in order for it to provide the health insights. And the second is the domain access agent, where you think about it as a doctors, right? So here I'm giving examples about if a user asks about what should be my blood glucose in 2 hours after a meal, the domain access agent will able to kind of first of all personalize these answers into this user's health profiles. So in this particular examples, the person have type 1 diabetes, so all the answers about their range is going to be based on that. And then they're trying to find out the credible references in order to back up their answers. Again, I think by the time 2 years ago, if you still remember, the language model have the being criticized for being able to too much hallucination on the citations, or even have not of the grounding evidence. And nowadays, actually, if you ask to ChatGPT or Gemini, you can probably see some of the reference over there already. But in our case, we specialize for the health domains. So how do we do it? We use more like the reasoning kind of structures. We're giving you the queries. The first step is to reason and make a plan for the investigations. But it provides the domain experts as a bunch of different tools, including online web search. Data Commons is actually pretty public health data sets, and actually not only just health but also other elements of the whole general global kind of perspectives. You'll be able to provide many kind of elements. For example, like given the user's age from 2025, what is the most common BMI range? What is the common activity kind of range, sleep quality range, etc. So you'll be able to contextualize the data from this individual person to be a little bit broader kind of population scale level. We also provide them access to NCBI APIs, which means they can basically query PubMed to get the latest research ongoing as well. So basically, these are different tools to give into the domain access agent who will be able to use them after the planning and then do the examination using these tools to get an answer to the users. If it's done if the whole process proceed, it will just like proceed. If it's not succeed, it will go back to reasoning stages with up to 3 times in order to try to get an answer for that. So the third one is the health coach agent, which aim to understand the user's kind of the constraints and preference in trying to provide a personal coaching experience. Think of it as a personal health coach, right? A human coaches. But basically for the question about if you're overwhelmed for social media, how can I set more healthy boundaries? A typical health agent output is never kind of give you one generic answers. It's first of all trying to kind of understand the user and trying to understand the personal kind of the reason and the goals a little bit more before giving you advice, right? If you think about you throw this question to right now generic generic language models, you'll be able to probably get a very long and comprehensive answers like, oh, there's 5 things you can try, things like that. But in our case, our health coach is trying to give the most personalized advice experience. Why is that? Because we're getting inspired by the health coach human experts. So we interviewed 11 of them who are actually professional health coaching experts, and then we're trying to identify the themes that during their conversation between the coach and their client. And most of the themes here, I think, are pretty intuitive and easy to understand, such as identifying the goals, active listenings, understanding their context, their preferences, constraints, and you're never making kind of like decisions for the clients. You're actually empowering them to make their own decisions, right? And also, of course, finally, incorporate their feedback to first of all to further improve the coaching advice to them. So we develop a kind of modularized setup, trying to instantiate these themes into a personal health coach agent. So you can think about as a bottom row about this pink box at the bottom. You can think about it as kind of memory structures where we're trying to remember users' goals, constraints, preference, feedback, summary of interactions, etc. And the main boxes lined over here is the main interaction kind of trajectories. Basically, as the conversation going, the model asks about self-inspect 2 questions. First of all, is this conversation at the right time that I can conclude? If it's conclude, it will jump to the conclusion. If it's not at the beginning, it will proceed. And the second is the recommendation module. It asks itself a question, is this a good time for me to provide an intermediate recommendation to the users or not? This is a very interesting insights we get as we're talking to the health coach and also talking to several end users for the insights. We figured that in the human-human interaction or coaching experience, the clients are usually more patient. They're okay with providing more, answering a lot of questions, giving the personal context so that the human coaches can really tailor their advice to them. However, in the human AI interaction setups, when they're talking to an AI agent coach, they first of all, they don't want a very generic answers, right? So they want to like ask a question and then get a very long answer that can apply to anybody. There's no personalizations. They still want some personalizations, but they are also relatively a little bit less patient. They want to get an answer faster compared to a human coaches, which is kind of understand because they're talking to AI. So there's an expectation to get even an intermediate level of the recommendations. So that's why we have this intermediate recommendation module that whenever it's the right time, after getting some context, I can provide a recommendation and then starting collecting feedback to make it more personalized. So that's why we have this modularized designs of the health coach agent to further improve the personalized coaching experience. So once we have each of the 3 agents together, then the next step is can we combine them into be a one kind of holistic personal health agent systems? This is actually what we do here, building a multi-agent systems. Well, in a typical way, you might be thinking about, well, if I have 3 agents, why don't whenever I get one question to the user, I can just throw to all 3 agents in a parallel, and then I get answer from all of them, and since I'm together and get back to the user, right? This is a very typical parallel multi-agent collaboration setup. But in our case, we believe we need a little bit more complexity on top of that because the 3 agents sometimes need to work together in order to get the most answer. But the best answer to the users. For example, data science agent could get insights. The insights is super critical for the health coach or the domain expert agent to give the personalized interpretation and then give the adaptive answers and adaptive recommendations to the end users. Right. So here's a typical example about one of the type of the complex user questions. It's like, oh, how's my favorite activities related to my sleep quality? Do I need to access more in order to improve my sleep? Even how should I improve my sleep? Right. So in this case, the 3 agents going to work together. The first paragraph, this is the clean examples, right? The first paragraph is about data insights. Second step is for interpretation from the clinical perspective. And then the last piece is starting transition into the coaching experience and provide the access, provide advice because the user is clearly looking for a advice on do I need to access more. So how do we do this? Well, before I talk to details, I just want to make a claim that we're not trying to claim that this is what the personal health agent in the future should do, as always. We're trying to provide one multi-agent architecture that we think are at least a little bit better than a vanilla multi-agent systems, which we're going to evaluate later. So here we just provide one solutions, and I think it's one of the reasonable solutions that we're trying to provide. And so we have a orchestrator, which is by itself also a language model. It's given a user query. It's trying to kind of assign among the 3 agents that we just developed, which of them should be the main agent, right? Think about it as if you're talking to a personal health team, like as a human team to support your health, you probably want to have like one major person to talk to, and that person probably can get insights from other team members and give you the insights. So our multi-agent kind of setup is trying to mimic this kind of real-world human team setups, where there's a main agent, there's also supporting agents assigned by the orchestrator, and then they're going to collaborate together, right? So for example, in this figure examples, the health coach agent is the main agent, and the data science agent is hired as a supporting agent. So the insights from supporting agent to data science agent can be fed into the health coach agent to provide a more personalized data insights so that the health coach agent can give the most personalized answers. So that's how the multi-agent can collaborate together. And before we get back to the user, we also add a self-reflection step to make sure there's no errors and then no mistakes, and then can like don't ask them like something that's already in the data, can review from it. So if there's something that we think we're missing, it will go back to the analysis step again and try to get answers up to the memory and get back to users. So this is basically how we are developing each of the single agents and how we're developing the multi-agent scenarios. So I fly through the slides really quickly just to give an overview about how the technical things we are working. I also want to share a little bit more about what happened behind the scene. Is actually with the help of nowadays language models coding agent, developing each of the single agents actually take probably the shorter the time that we expected. So it only took us probably 1 or 2 months to iterate, of course, but to develop the majority of the systems. The next thing, the evaluation, is actually the most time-consuming part. So I'm here to give a high level, just like a broad overview. It's overwhelming by design. You don't have to look into any details, but basically we're trying to do a very comprehensive evaluations of each of the single agents' capability and also the multi-agents capability. This blocks is probably more informative, but we're trying to be as comprehensive as possible. We include both single-turn, multi-turn conversations. Data modality includes single modality and multi-modalities. Evaluation including both auto-eval, which means rubric-based language model as a judge, and also human eval, which from whenever it's human eval, we're trying to kind of include both of the perspective from the end users and the health experts. And this actually requires a huge amount of efforts, thousands of human hours to do the comprehensive evaluation. This is the part actually is the most time-consuming and load-bearing for us. So in the next few slides, I'm going to give a high level. I'm going to pick 1 or 2 agents to give a high level overview about how we do the evaluations, just to give you a sense about what this evaluation benchmark would look like. So in order for us to ground our evaluation in the real world, we leverage a data set, a study called WearMe, study in the WearMe data set that's collected from around 1,000 people. That's all collected by Google. And we have the data from their wearables in the past 3 months. We also get everybody's personal health record on their blood pressures. So it's think about it as a simpler version of the EHR. It's not as comprehensive as electronic health records, but it has some readings and then blood test reports. Also the surveys that tell us people's health conditions as well. So this is the data that we can ground upon for us to do any of the evaluation later for data analysis, personal kind of health insights, and also the coaching advice. So I think I'm going to take the data science agent as an example to give a deep dive about how would they evaluate the capability of the data science agent. So remember in this slides, we show that there's the 2 steps the agent's going to do, right? First of all, generates the plan, and the second step is writing the code to do it. So how do we make sure that the agent can actually do a good job on both the steps? So this is actually 2 tasks we're trying to do, where each of the steps, we have a task to aim for to see whether the agent can do a good job. The first one is the data analysis plan generation, right? So every time user asks questions like this, how do I get more sleep the days I stay more active? It's often the open-ended queries. They can be interpreted in different ways. They can also lead into that there's no single best data analysis plans that come out of it, right? So let me give you another example, which is all the steps here written by the human experts. Am I better cyclist than I was 2 years ago based on my data? Right, so if a human experts doing this, they're trying to say, well, we should first filter for the data. We're going to check the data, the types, and then we're going to calculate the metrics for each period, and then we check the distribution, run the test, and then give the results back to the users. Right, this is one of the typical plans written by data scientists, human data scientists, but maybe there are some other ways of doing analysis as well. So in order for us to kind of quantify the capability of the data science agent, we first of all prepare a kind of a benchmark with all the data science queries and analysis plans to as a grounded way for us to see how we can evaluate the plan. So we first of all sample 100 queries from an anonymous user query set. If you remember in stage 1, we first trying to understand the users, what they need. We actually get about over 1,000 queries from the real world. So here we are trying to select 100 from them, and then 10 data science experts actually annotate, given the queries, if they are going to be the one trying to answer these queries, what are the analysis plans they're going to have? So each of the queries, they're trying to write the ways of a good data analysis plan. So because, as I said, it's open queries, one queries can be interpreted in different ways. So that's why we write more than one. Actually, we're writing about 350 annotations for these 100 queries. And based on these queries, we can use this 354 kind of the query and analysis plan as a benchmark to do two things. First of all, we can use it to kind of give them examples to a language model, saying, hey, these are good examples that human can write, and you'll be able to kind of follow these examples to write a good and comprehensive comprehensive analysis plans. And the second, using these 200 cases, we can also develop identify what are the key things that a data science activists find useful, and how can we use this as to develop a rubrics to analyze and annotate whether this analysis plan is actually comprehensive or not. So we identify 6 dimensions of the evaluation rubrics. First of all is timeframes. Whenever you answer questions, the analysis plan should identify a good timeframe to analyze. Second, you should do a good job on the transformation. You always check whether it's sufficient or not. The third point, 4 and 5 and 6 is about other perspectives. So once we have the rubrics, we use it as a kind of like a point deductions process, where it's like whenever the query should be involved in the time frame part, we can be able to check whether the plan written by a language model or by a human have this time frame aspects or not. If it touches it, it will earn a score. If it's not, it will like lose a point on top of it. So we can see basically the more points you lose, that means the less comprehensive the plan is going to be generated. So apparently these are the 6 high-level dimensions. We actually, in each dimension, so we have a further break it down into different, you can think about it as a decision tree of the way to basically a rule, a kind of like a scoring kind of systems. And in total, there are about, I think, the 26 or 30-ish of the points to earn or to lose. And all the details actually in the paper. I probably won't dive too deep into it. So once we have these rubrics, we can then ask a language model to kind of give them a query, generate a plan, and then to use these rubrics to evaluate how many points that these plans lose, right? So the less points you lose, that means the better the plan is going to be. So we can compare our data science agent with another baseline language model to see the quality of it. And if you remember, a couple of minutes ago, I was talking about in this kind of all the data agent that we've developed is think about it as a shell that can be hopped on any of the language models, right? So in our evaluations, we took Gemini, I think 2.0, 2.5 families as the base models, and then our kind of like the think about it as a prompting structure that sits on top of the language model, the base language models, and we can evaluate the delta of the performance to see whether this whole framework is actually helpful or not. And in the future, we're actually going to be releasing an open source version that we can replace this Gemini to be any other frontier language models or open source language models. But here we're going to first evaluate about the quality based on the rubrics, right? So higher means they lose less points, means they're doing a better job. So we can see that, first of all, compared to the base Gemini, the statistical analysis part, we don't see any improvement. That means the base language models already do a pretty good job over here for the running, like finding out the most appropriate statistical analysis. But we observe the significant improvements on all the other aspects. We especially look at data availability check, which is kind of funny because if you think about like sending your personal data into a base Gemini and ask your questions, it will almost assume that you always have the data and don't look at whether you have 1 data points or 10 data points that can give you a reliable answer. And this will be able to address significantly and improved by our data science agent by looking at the data availability. So this is something that Gemini would almost skip almost all the times when you were using the vanilla language model. And all the other aspects we see improvement as well. So after benchmarking the capability, the first step of writing a good plan, the second is can we write the code to exercise these plans, right? So in the second task, we try to evaluate whether a language model can write a good code. And in the field of the software engineering, in the way to see whether your code is actually good quality or not is to whether you can pass some unit test. So we basically follow this paradigm that in this second task, we took the best 25 analysis plans from the first task, and then human experts, again, try to develop a unit test to see whether any code written by a language model or by human can pass this test, right? The more tests they can pass, that means the better they are. We can look at in different type of scenarios what kind of errors they're making, and then the less error they are, that means the better the code or more the comprehensive code that they can be able to write. So you can think about for a query, then the test could be, oh, what if the data is kind of like, I mask some data to see something that is missing, see whether the code can identify this, right? If I skew the distribution a little bit, so I can see whether it can identify the best statistical analysis to it. So our data science experts, given these 25 plans, write about close to 200 unit tests, and then we can run this code through this test to count the different type of errors made by the language model. So we can compare our agent with the base Gemini as well. And also, this time, we can see that from some perspectives, the base Gemini already do a pretty good job, right? The output content errors, language model barely make a mistake like this. Calculation errors, also not very common. Also, it's already pretty good. And general programming errors, also pretty rare. And our data science agent were able to improve them, but the improvement is not very significant. The biggest improvement we see over there is data handling errors, right? That means that given our the two steps with a plan generated already, and also with more examples given to a language model, it will be able to handle the data transformations, checking the data sufficiency more effectively, and reducing the error significantly by almost cut half of the error rate. So that's a quick high-level overview about the data science agent. And given the limited amount of time, for the rest of the two agents, I'm gonna fly through on the domain experts agent and also the health coach agent. And so the domain expert agent, again, think about it as in doctors. Probably the first two tasks are actually probably already seen quite a lot in the recent publications. Basically, sometimes saying, oh, a language model can outperform a doctors, right? Because why they're saying that? Because they can pass the human exams. And then so this is something that we also tested on different type of the question and answering data set. Second task, we ask them to analyze a multi-turn conversation between human and a doctors or a agent, and we're trying to do a differential diagnosis based on the conversations, right? So we can see that our agents were able to improve on top of the base Gemini, by some percent, but not a lot. The third task where we ask a language model to give any of the query health questions coming from an individual patient. We're trying to whether a language model can give a personalized and a contextualized response. And then we compare them to a base Gemini as well. We're rated by the end users. Then I throw a question to the user. They're going to see two answers, one from our version, one from the Gemini, and you're going to raise on top of it. So we can see that from the relevance and groundedness of the data, both models all do a pretty good job, but our model could achieve much better job on the trustworthiness, mainly because they can provide the citations, they define the medical terms in a better way, provide a better presentations, and the contextualizations, right? This is where we observe the advantage of our domain experts. In addition to asking end users to evaluate, we also ask health experts to do evaluations. Where in the fourth task, we ask our agent to be able to summarize a comprehensive multi-model data structures. We send all the text data, structured lab readouts as the PDFs, and also the wearable data as a CSV file. All of them dump them to the health agent and try to ask them to do a good summary. And we have 5 experts to rate the quality of the summary from different perspectives, right? The soundness, accuracy, consistency, etc., etc., etc. So here are the results. We can see that compared to the base Gemini, we can see the base Gemini already do a pretty good job on the accuracy, clinical soundness, and clinical consistency. But our agents improve on almost all the other aspects, including the better cross-model association, be able to combine different source informations, more comprehensive results, more verifiable resources, and doctors overall find that these results are going to be much more useful in the clinical domains before seeing the doctors. Right. So this is examples that to try to evaluate the capability of our domain expert agent. Health coach agent, I'm going to skip because the evaluation is very similar to the last part of the evaluation, which is a multi-agent systems. Because after we combine all three together, the evaluation cannot be isolated and also cannot be just offline evaluation because now it's supposed to provide a real-time conversations. So how do we do this? Well, we actually recruited 45 users with a diverse health background to match if you remember, we collected 1,000 people's data set. So in the ideal case, we wish that we could recruit users who bring their data so that we can analyze their data on time and provide a personalized advice. However, it's a little bit hard to be able to recruit the diverse population with different health conditions and have the data ready to be shared with us. So what we end up with a role-playing kind of setups where the end user can play the role of the data set we already collected. So basically, is we first of all recruit a user with diverse health background, and then given each of the users their health conditions, their age, their gender, we're trying to match the most relevant data points that we have from the WhereMe, and then basically let any user to read the data from other people that have similar backgrounds and trying to play a role so that we can kind of bypass the data availability process into these evaluation steps. So our 45 end users have, I think, about 30% of them are healthy, and 70% of them have different health conditions. And we're able to match each of the users into a best matching kind of persona from our WhereMe data set. And once they are matched, the end user can play a role of this persona and then have a real-time interactions with different agentic systems. And they're going to evaluate based on their conversation experience from the overall conversation qualities, special capabilities from data science, domain experts, and health coach, and also the overall organic integrations of these skills. So we compare our multi-agent systems against two baselines. The first is the one that I just mentioned about the parallel multi-agent systems, where every question is going to be sent to all three agents at the same time, and then be able to provide a kind of synthesized answer in a parallelized way. The second baseline we're trying to look at is, well, we're trying to look at multi-agent systems. But if you think about each of the agents, they're just a bunch of prompts and the tools. So there's a very natural question is, can a single agent will be able to achieve all the tasks together, right? So we provide all the same tools, the same kind of architecture, the same similar prompt structures, and all the tools to a single agent, trying to see whether it can do the jobs in these conversations. So in our evaluation task, the 45 end users were able to talk to 3 agents in a randomized order so they can try to evaluate the experience of the 3 agentic systems. So we can see that our multi-agent systems actually will be able to provide a much more better kind of natural interactions, kind of more personalized coach experience, interacting the data from different perspectives and providing overall better overall qualities with the better data analysis results. Right. So this is a kind of an evaluation on the user side, where we also as see that when they're trying to ask them to rank the 3 agents, well, we just see that the multi-agent systems will usually rank among the top. In addition to the end user perspectives, we also interesting from the health experts perspective is whether these agents actually from the doctors or health experts, whether they are actually doing valid results, whether the advice is actually correct, things like that. So we asked 3 health experts to also read these conversations from task 1, right? Because each of the participants have interactions with 3 agents. They're going to read all 3 of them and then blindly rate on their perception of the quality of this agent conversation and the agent capability. Now, different from the end user perspective, their perspective are more cared more about clinical validity, correctness, and then the overall coaching capability, etc. So compared to the overall, the findings are pretty conclusive to this aligned with the end users as well. But we're able to see actually a little bit larger effective size from the experts' perspective. Experts think that almost all the perspective we see the significant improvement of our personal health agent and compared to the single agent scenarios, and then the ranking is overall like more like dominating from the multi-agent scenarios as well. Although we do want to kind of highlight that there's an interesting point where the experts see a bigger advantage for the multi-agent PHA systems compared to the baselines, where for the end users, I think we did see the best performing improvement of the results, but the effect size are relatively smaller. Right? So this is an interesting perspective about the experts. First of all, it indicates why we need evaluation from both perspectives, but at the same time, that raise interesting open questions that of all the things that we are trying to do here, did any user actually feel the the difference or the improvement, right? We see some of the improvement, but probably there's the delta is less than the expert side. This also gives us to think about how should we balance the efforts we're putting into the systems, and then whether you can use it, can actually fuse it, right? So this I think is a open question for us to think about when we're developing agentic systems for the consumers and end users. We also actually have a scale-up evaluations, but given the time, I'm probably going to skip. Basically, we ask language model play the persona. There's more data to evaluate. The results is pretty consistent. We see improvement on almost all the aspects from both end user and health experts perspective in a simulated conversation, but in a much larger scale of evaluations. But again, to wrap up and provide an overview about this work, we start with a very user-centered approach, understanding what user actually needs, and then we design a specialized AI agent systems, integrating multi-user systems, and then do the most comprehensive evaluation out of it. This is again an overview of the whole research framework, and I think the biggest takeaway is that evaluation is really, really important. Right? The development of the process is quick, but the evaluation is a thing that takes most of the time. And the one thing that I do want to highlight that in here, by the time we're developing the systems, they get a chance to actually put them into the real world for the evaluation, right? Our evaluation for the multi-systems, although it involves real-time interactions, it's still a relatively controlled lab study where the user comes into a lab and interact with an agent, not in the real-life scenarios. And the real life scenario is really important. That's why I want to briefly mention this work where we also build a multi-agent systems by trying to provide a personalized mindfulness experience in the real world, right? So in this project, we develop a multi-agent systems and deploy them in the real world. And there are 4 weeks of the mindfulness training and then a free interactions with agentic systems to practice the mindful experience. So this is where I think we should also emphasize that once we've developed multi-agent systems, it's really important to put them into real world and see how they actually do. Right. So overall here we can see it can better when the agent provides more personalized advice, people are more kind of encouraged to engage with mindfulness practicing, and also see the improvement on the mindfulness and on the positive mood aspects as well in the real world scenarios. So this is the part where come back to our multi-agent personal health agent framework. That's also something that we are already trying to do as well. So this is last month, Google just announced the health coach become globally available, and our kind of the framework is basically inspired this product and the science behind it. So this is, it's not exactly the same because product and research prototype are always there's some difference, but this is an example about we'll of course do some internal testing in the real world as well. And now it's launched globally to see how people are interacting with a health coach agent. So the more next step idea is trying to see, well, can actually this health coach agent actually improve people's health and well-beings from a data perspective or from a subjective perspective. This is something that we're going to look into in the next steps. Right, so I give a pretty kind of high level, but also sorry, I speak pretty fast, dense overview about how AI systems can be used to support consumer from their health and well-being perspective. Given the time, I'm gonna probably just very quickly walk over some examples on the AI systems, how it can support for the health experts perspective. So, well, we have talked about wearable data have been really useful, but actually there's a first question is that, well, this data is actually useful from the clinical task perspective, right? So using the data from all of us, we're able to actually find a good overlapping between the wearable data and the EHR, and we're trying to see whether combining these data sources together can improve the performance on different clinical tasks. And the answer is probably yes. Across 40 different diseases that covers 9 to 10 different disease categories, we're able to see that wearable data can consistently improve the model performance across different EHR baseline models. Here by EHR baseline models, we include like OMAP-based like logistic regressions, or nowadays foundation models from EHR has become popular, and we also try to incorporate a couple of the foundation model, EHR foundation model as well. So on top of this EHR models, we're trying to add the data from wearable data, add the data from wearables, and then trying to train the multi-model data together. We were able to see that just by adding in the wearable data, we can see a huge boost on the performance on multiple different clinical tasks. So the takeaway from these 2 slides is basically, well, wearable data is actually can be helpful for the clinical tasks. Well, the next step is then, let's go back to the first, like the opening of the talk, is like, how can we actually make it useful for the health experts and make them who are probably not trained on leveraging this data and trying to make them to improve their decision makings now with the help of the AIs. So in the probably next 5 minutes, I'm going to give a very high-level overview about a recent mental health clinical dashboard that we developed, and together with the mental health clinicians. So as I showed earlier, the wearable data is actually useful for many clinical tasks, and in the mental health cares, people are realizing that the data from the passive sensing is actually pretty insightful for capturing the patient's behavior before their visits or between their visits when they're not in the clinics. It's important to know what is going on for the patient, so that during the regular visits, the insights from the people when they are outside clinics is actually pretty helpful. So there's a general idea about, given the existing data such as clinical notes and transcripts, how can we combine with the other passive sensing and probably some survey data together to synthesize them as insights to the participants? Well, that's an ideal case. Well, what is a counter practice is that there's a data dashboard where the dashboard is saying, oh, we have all the data from there. Why not let's present them together to the doctors? This is not going to work. Is, first of all, doctors are super busy. They are, by the time they're seeing the patients, they will have a couple of minutes. They don't have time to dive deep into the data, especially for the passive sensing, which is multi-model, time series is super complex. It's impossible for them to quickly dive deep into them to get insights. Second, they're not really trained to do that, right? So the overall vision is trying to do is, can we kind of develop a computational pipeline to curate a set of the data insights from these different multi-model data, the data sources to kind of tell a story to the user, so the user here as a mental health clinicians can quickly get the gist out of the patients, and then so they can better prepare for their conversations. So we trying to co-design a dashboard with different experts through a major iteration cycles. And here's what we get for the final dashboard, which we call as a MIND. It's a multimodal data integrated narrative dashboard. So let me quickly walk through about what this data going to do. So first of all, on the left-hand side is like all the kind of visits history. It's a linear kind of trajectories, chronological order, where you can see what is the last sessions you talk about and what happened to the users, and then what are you going to talk about today. So you can see on the top, on the right-hand side is all the data details. So you can see the medical history of this patient. You can see the recap about what you have talked about from the last conversation, summarized from your transcript. And then the most probably critical piece, which is the patient data insights part, is what happened to this user between this visit and their last visit, right? In this case, it's about months of data. And then we're trying to using a computational pipeline to capture something that is interesting, either inspired by the session recap. There's something you talked about last time. Oh, should they look into your sleep? And then the analyst is the insight gonna look at the sleep as well. Or there's some interesting trend or outliers in the data that we think that clinicians can pay attention to. Right? So this is organized as insights cards for the clinicians to quickly navigate and then skim through. If they find one of the cards are pretty interesting, they can also dive deep into it. They can click on it and then see where is the raw data that actually support this data insights claim. So this, we can see the survey scores, the passive sensing data, if it's relevant to one inside the card, so they can navigate and track the validity or the details of these results. And once they get the insights, the last piece is summary today. They can select the different insights to send to the patients, and this is to facilitate the logistical steps with the patient provider communication. So this is a interactive dashboard that we developed that we can synthesize all the information together. So it's a very high-level overview about how do we do it. Well, we use a language model empowered, but also we have a bunch of rule-based hybrid pipelines, and you can transform our raw data into the data insights. So we have 3 steps. First of all is the analyzers. Think about it as a data scientist agent I just talked about, right? You can basically inquiry from the data, generate a plan, and then run the code to run analysis to look at comparisons, trend, outliers, etc. Synthesizer is, once we get a bunch of the data facts as the bullet points, right? The things that are going to basically pull the different points together to generate the actual insights. So the insights could either came from guided synthesizer, which is basically from your previous conversations, last session recap, or a little more exploratory, which means you get the data from different like sources you're looking to. Oh, what is interesting, clinical interesting kind of outliers, or something that needs to be paid attention to, etc. So they're both the combination of guided and exploratory. Once you have data insights, the last step is to narrate, like organize them into tell a cohesive story, like putting them different insights cards, rank them in a certain way so that the clinicians can quickly looking through these insights cards to get the insights. So for the evaluations, we allowed our dashboard and with one baseline dashboard where we basically just show all the data, which is a typical data dashboard that currently practice has been doing. And then we evaluated with 16 mental health clinicians in a relatively controlled setups where they use 2 dashboards to view 2 patient cases and compare the experience based on the surveys. And then our results shows that our dashboard were able to help the clinicians to discover more hidden data insights from this multimodal data, and it can assist the clinical decision making with a higher efficiency, usabilities, and cohesiveness, etc. And the clinicians comment that overall this dashboard can do a better job on predicting or helping them to make better decisions on top of the multimodal data. So this is a very kind of quick overview about how the AI systems was not only be able to help with the consumers, but also with the health experts as well. And combining these things together, the overall job, let's say, giving you these examples of how we can develop a more human-centered AI systems with co-designs, with understanding the users, what are their needs, so that we can develop systems to better support their needs. So again, by combining the 3 areas together, we can aim towards the goal of building an intelligent, the human AI ecosystems to improve health and well-being. And this bunch of work is almost impossible without all the lab members and collaborators are called for them. I really appreciate it, and really appreciate the support all throughout the process. And I think that's it for the talk. And then thanks for your attention. Our lab is always open to the conversations about any positions, and happy to reach out. It's a great pleasure to be here. Happy to answer any questions if you have time. So thanks.
Very, very impressive, Orson. Thank you very much. Looks like you are realizing the promise we saw when we invited you to the M Health Institute. That you can only do that when you're up in a space capsule out there. Don't know how you do that.
First of all, thank you for saying that. Second, I think I think it's not 2 years ago, right? It's the time I did the MHTI thing. I think 2 years is probably too short to realizing the visions, and there are probably 10 to more years to go to make sure each step is actually to validate and put them into the healthcare system. That's the final goal, and that's a hope.
I love that you're working with Google so you can productize many of this exciting technology. We are at top of the hour, but let me open it up to the audience. I see Katrina from Katarzyna from Switzerland. It's late for her. Any other HCI specialists out there who want to pose a question? If not, we will let you go.